Good afternoon and welcome to today's program, Integrated Care is Now, a case study on integrating behavioral health and primary care. I'm Dennis Grantham, Editor-in-Chief of Behavioral Healthcare Magazine. Today's program is made possible by our sponsor, the Echo Group. And, of course, thanks to the folks at Echo and to all of you in our audience for giving us your time and attention today. Before we get started, we have just a couple of housekeeping details so you'll feel comfortable in the process of watching this program. Today's program is, of course, interactive. Our speakers will answer questions at the end of the presentation, so please use the Q&A feature, which is indicated over on the side of your screen, to submit a question at any time during the presentation. Note that there's a scale button up on top of the taskbar that's noted in red that can help you scale the presentation slides to better fit your screen. And of course, on your left is a box labeled Handouts where you can download a PDF copy of the program slides. For those of you who are seeking CE credit today, you must be registered for today's program to receive that credit. And during the program, 2 messages will appear right in the center of your screen. Each of those messages will have a little number in them. If you're participating by yourself as an individual, simply enter the attendance code, which appears, into the little box on your screen to verify your attendance. That'll happen twice, and that will be required to generate your CE certificate. If you're attending as part of a group, then write down the code on a piece of paper each time it appears, and then when you get a follow-up email after being registered for today's program, after the program is over, you can use a link that goes to the CE credit function and then enter your little number there, and that will register you after the program so that you can get your CE credits. So hopefully that's clear. It's real straightforward once you see it. We also invite you in the audience to share some thoughts on Twitter. The event hashtag is INTCareIsNow. At this time, it's my pleasure to introduce today's speakers, Steve LaFleur and Joe Viget. Steve LaFleur is a counselor who has worked with IT and EHR systems for the last 15 years. He's been part of teams that have implemented EHRs at the first behavioral health organization to win the Davies Award and the Negley Award. He also led Grand Lake Mental Health Center's effort to be the first behavioral health organization in the country to receive EHR Incentive Meaningful Use Funds. And of course, Grand Lake is located in Oklahoma, I believe. Joe Viget joined Echo in 1999 and has a diverse behavioral health background, including case management, managing residential systems, and community-based treatment teams. He has 10 years of experience in behavioral health environment. Joe was Social Service Director for New Hampshire's largest public housing authority, where he was instrumental in developing and directing programs that address substance abuse, home ownership, unemployment, at-risk youth, and geriatric issues. Mr. Viget is on the board of the Software and Technology Vendors Association. So thanks again to all of you and to Steve and Joe for joining us for this presentation. And with that, I believe, Joe, the audience is yours.
Thank you very much, Dennis. Good afternoon, everybody. This is Joe Viget. Today we're going to talk about integrated care. Many providers have been struck by statistics that persons with mental illness have a lifespan 25 years shorter than average and are challenged often in accessing adequate primary care. From this perspective, delivering integrated care is a logical extension of most behavioral health organizations' mission. Other behavioral health leaders are looking at this issue and viewing an opportunity to ensure the viability of their organization in the shifting sands of healthcare reform by establishing new partnerships and accessing new revenue streams. I think in the end, whether you're driven by quality of care or concerns about funding, or whether you're reading other tea leaves in the future of behavioral health care, forward-thinking behavioral health organizations are taking a very strong look at how to deliver integrated care today. All across the country, plans are taking shape to integrate behavioral health care and medical care. I just returned from 2 major conferences as well as the SOTFA board meeting last week, and I can tell you that integrated care is well represented on these agendas. The ECHO Group recently released a white paper on this topic, and the interest in that has been, frankly, off the charts. So today we're very excited to sponsor this webinar on integrated care and try and spread some information about this important trend. The ECHO Group has a variety of customers actively involved in integrated care projects. Several of them are grantees in SAMHSA's Primary Care Integration Grant Program, and we congratulate all of them on their hard work. The integration approaches they're taking are diverse, and many of them are in the early stages of this process. In this regard, we've worked with Mike Lardier at the National Council of Community Behavioral Health to convene a user group of these customers, and their work is progressing quickly. But still, as you look over the broad landscape of behavioral health care, finding concrete examples of organizations who are actually delivering care and delivering integrated care is still relatively rare at this point. And that really brings me to today's primary presenter, Steve LaFleur. As Dennis mentioned, Steve has a master's degree in counseling and is a licensed clinical professional counselor, so he has a bit of a unique perspective on the topic. He worked for an ECHO customer in Illinois, Heritage Behavioral Health, and as Dennis referenced, that organization was successful in winning the Davies Award and the Negley Award, and Steve was part of the teams that worked on those initiatives. Early in 2010, Steve moved states and changed positions and found himself in a role as Chief Information Officer at Grand Lake Mental Health in Nowata, Oklahoma. And there he's continued to lead progressive projects related to behavioral health information technology. Notably, last year, Grand Lake was the first, as far as we can tell, as there's no official registry, but the first behavioral health organization to be awarded EHR Meaningful Use Incentive Funding. Now, just about a year later, Steve mentioned earlier that it's just about the anniversary of their award. That process has really come full circle as Meaningful Use Funds are driving Grand Lake's implementation of technology in support of the delivery of primary care services in their organization. I first met Steve at a CWLA conference on Cape Cod during my very first business trip as an ECHO employee. He identified himself as a clinician, and he told me that after the conference he was driving up to New Hampshire to visit ECHO's corporate office for training. It was 1999. In those days, we didn't see too many clinicians being trained at our home office. Our systems were really the concern of financial parts of the organization at that time. It's safe to say Steve brings a very unique and valuable perspective on this work from the clinician standpoint and moving over onto the technology side of an organization. We're honored to have Grand Lake as one of our customers, and we're thrilled to offer the opportunity for you all to hear more about their organization. So with that, I'm going to introduce Steve LaFleur to you all.
Thank you, Joe, and hello, everyone. Real excited about the possibility and the reality now of sharing what we're doing here at Grand Lake. A little bit about Grand Lake, at least right now. Just got a slide here, just sharing a little bit about our agency, just some of the basic demographics, and speaking to the point of the integrative care. The journey for us really began almost 18 months ago. We had started hearing about the possibilities of integrative care, and that seemed to be the way things were moving. And so about 18 months ago, we took the opportunity to visit a couple models of integrative care in a neighboring state in Missouri. And we went to 3 or 4 different agencies and looked at different models, and that kind of got us thinking about what the possibilities might be for us. Here in Oklahoma, you can see some of the basic demographics for us. I should mention that as an outpatient agency, we are in the schools. We work with the court systems. We do most of our outpatient across the age span. We do not do substance abuse directly. We treat it as co-occurring for us. We do our medical, our psychiatric visits, and have been for quite a while via telemedicine. We're in a very rural part of Oklahoma, as you can see, covering about 5,000 square miles. The state of Oklahoma has made a heavy investment in a telemedicine effort, and we took advantage of that early on. And almost 2 years now, we've been doing telemedicine for all of our psychiatric visits. So we do about 1,100 of those monthly, where our doctors are at the site I'm at right now, and our consumers come into the various office locations and are getting taken care of by the psychiatrist over a video screen. We, as part of our effort thinking about integration, we had heard about the funds that were available for EHR, for incentive funds to help with that, and had been keeping our eye on that. And Oklahoma, luckily, was on board with that program very early on, and we heard from them about a year ago in January that they were ready to disperse the federal funds. And for us as an agency, it was, well, how can we get some of those funds and take advantage of that, because we were looking for a certified EHR. We had been an ECHO customer for quite a long time, and in my contact with ECHO, they had assured me that they were on the path towards certification, and I was pressing them for, in January last year, when's the date, when's it coming, and so I believe it was early February that got the word that the record was certified, and as soon as it was certified and we got the paperwork, we were able to attest that we had this implemented, or we had this available, and once that certification was in place, I sent the application in to the state of Oklahoma at the end of or beginning of March, I believe, and within 30 days we had the funds in our accounts. The first round of incentive funds, I don't know how much everyone knows about the incentive funds, but the idea of having a certified record and us desiring to, we were already ahead because we had it already implemented, but that first round of funds really was not that difficult to achieve once you could say that you were going to be a part of a certified record. And we got that first round of about $63,000. That was a big boost for us last year as we started moving forward. The idea of the certified record also lends itself to the reality that in order for a behavioral health company, I believe, like ECHO, to get that certified record, they had to begin thinking about some medical measures, things that weren't normally in a behavioral health record. So the beginnings of physical care and medical care along those lines were going to be built into a certified record, things such as vitals and BMI. Those were things that, as a behavioral health agency, we were never worried about directly, but now with a certified record, some of those pieces would already be in there. So it was good, and we were glad that ECHO was on the same track with us to have the record certified and assist in getting those funds. So if you're in an agency right now where your state, I've got the main website here. You can actually go to this website and see the status of your state information, whether or not they are ready to disperse the funds. And if you've got your eye on any type of certified behavioral health record, you are eligible for those funds and can apply through your state to get those. There are some other pieces to that, but I encourage any agency that's looking at a record like that to go ahead and look at that application and get those funds right up front. Let me move on to talk a little bit about where we're at as an agency now. One of the biggest challenges, I think, in thinking about integration, we had, as I said, we've been thinking about it for for over 18 months and how we might implement it. But the reality is that at our core as a behavioral health agency, and I think for most behavioral health agency, it's always been, we do behavioral health and we do it well. And that's what we built our mission statement around. We pride ourselves on it. We do this one or two things, really well. And when it came to medical care, that was something that other professionals took care of. We definitely wanted to consult with them and work with them, but thinking about doing that ourselves just kind of worked right at our core on whether or not we even should do that. So should we provide services or to children or adults or outpatient? We make those decisions along the behavioral care lines, but when it comes to medical care, the reality for us was integrated care was going to mean that for us it was going to be a proverbial paradigm shift and a big one. And I think it's that way for any behavioral health agency to even look at and say, are we going to have to change our mission statement to even do this? We had looked at our mission statement a number of years ago, actually before we even started thinking about integrated care, and opened it up to just basically providing integrated care. And we did that back then, not even knowing what that would mean. But now we're finding out what that means. So the question of should we do integrative care as a behavioral health agency, I think if you're a behavioral health agency today and you're thinking about it, you've got to get through that challenge of fighting your basic core beliefs and saying, we've got to find a way to get beyond that if we're going to be involved in this process. And so for us, it really was taking ore out of the picture and starting to think about and this has to come, and it did in our agency as well. It has to come from the top. This desire to do this. Our CEO Charles Danley and our Chief Operating Officer Larry Smith have emphasized ever since I've been here for the last 2 years that this was something that we were going to do, and it's looking at this mindset of we can provide quality services and be financially solvent. We must have a mindset of being willing to do things that we're not used to doing. So is it possible to do all of these things? If you've got that mindset and can begin to think along those lines, the medical record provides us information about our consumers. Physical issues, as I suggested in a certified record, are already, some of those pieces are already there. Medications, which we've been prescribing for years, still are going to be prescribed. There's a lot of things that are common in the two disciplines. So if we have the mindset of the only thing that really remains is just the planning on how we're going to pull it off. So you can see all these and statements and things that we had been thinking about and had in our processes for behavioral health. It was just adding another piece to that. So for us, we felt it was possible. I know there's a number of different ways of looking at it, how we're going to integrate, and I had suggested that we had visited some models and seen some ways to do it. And just briefly, for us, we've been referring for many years and coordinating with our local health providers, and we would make a referral and try to do the case management to follow up and make sure they followed up with the primary care physician and get our release for that, for that office. And try to make those connections and work with that. But with the quantity of cases that we had and just seeing where things were at, I think that's the way most behavioral health agencies have worked, and that has not been enough. Our population, Joe suggested the statistics, dying much earlier than they need to, and there's got to be a better way. And so this idea of integration, I think, is here to stay, and look forward to the impact that it can make. The idea of co-location with the same services in the same building, not being linked, this was one of the models that was very helpful for us to see when we visited in Missouri. The biggest challenge that they suggested to us was it was nice being on different sides of the building, but the idea of not being linked administratively created some issues they had to work with and keep working with. And then the whole idea of just the two different disciplines and the language differences and the way they approach care and working through those issues. And they had been at it for a number of months and in some cases years, and still were working with that. But that was helpful for us to be able to see what that was all about. The idea of consultation with medical health providers visiting the primary care setting on a regular basis and possibly providing services mutually at each site. Oklahoma had started about a year ago now to want to see what could be done in this model of integrative care, and one of the first things they did was offer to pay for some primary care for some of our consumers at a local FQHC. And they identified that they could cover about 25, so we were able to identify 25 clients of ours and assist in getting them over to the FQHC, and they would provide the medical care, and we would have a lot closer case management. That has presented some challenges still in having access to each other's records, timeliness of the visits, what information is able to be gathered. So, and then we still continue that to this day because the state's still following that. The other piece related to that was we knew last year about a year ago that there was a group in our county areas that we cover. There was a group that wanted to apply and had applied to start another FQHC in our area, and they did not have a building identified, and we were approached and asked if we had some space, and we did have a space at one of our sites that we offered. If you got the FQHC, we would be glad. We've been thinking about this. We would be glad to offer our space, and you can have the FQHC there until you could get a building up and utilize. So we were hoping that there would be an FQHC actually in one of our buildings. I believe it was last fall, but they got the word that they did not get the grant to become a new FQHC. So that was a setback. But shortly after that, the realization that this mindset of and wait a minute, we had already committed to offer this space, and they were going to come in and make it more of an exam room type setting. Would it be possible for us to use the same space and remodel it, make it an exam room, and see if we could provide those services? So when we decided that was a way to move, we brought on board someone that their primary job was integrative care coordinator, and they were from a medical setting, so they knew the language. They knew what was needed, exam room wise, equipment wise, regulation wise. and she came on board pretty shortly after that and started to work. And I should say that at least right now we are, in fact, Wednesday's the day we've got identified right now. Our PA is seeing clients right now on the medical side. I believe we've got 8 scheduled today. We started about a month ago, about 6 weeks ago, and have been providing the integrative care. And have been doing that through our existing behavioral health record that we've added to, so that it could also serve as a record for our medical care as well. So let me move a little bit into the record with some screenshots. What you're looking at right now is a picture of what ECHO calls the VHR, the Visual Health Record. And it basically is a very client-centered look at what's going on at a single view of a client's treatment. And it's customizable, and we've customized this right now. This is the medical view, so we've set this up so that the things that they can see right up front without digging any deeper in the record are, of course, basic demographic information up at the top. You can see the client would be identified. Where it says VHR up in the upper left-hand corner would be a place for the client photo, so they would have a picture of the client. Again, the basic demographic information, and then we wanted our physicians to be able to see what the current diagnosis was, and in this case, it would be their behavioral health diagnosis or any physical health diagnosis that was entered in the system would be seen if it was an active diagnosis on this screen. The second one is medications. If there were any medications that are being prescribed to the client, whether that was done by the psychiatrist or the medical doctor, those also would show up here on this view. It also shows the current status of the client's treatment plan. This might not be as important for our medical doctor, but the psychiatrist can see it. But in some respects, the medical doctor would know that they're in treatment, they have an active treatment plan, and then all of the information below, they could see appointments that were kept. The red X means that the client had an appointment scheduled and it was a no-show. If there's a blue dot, that means that there's an appointment there. We can do some neat things with the icons in this record. So I believe it's on April 16th there. I don't know if you can see it very well, but there's a little face there, and right now that's a frowny face because that clinician hasn't completed their progress note. So they can see at a glance whether or not the progress note is completed or not. And for a clinician, when they view this, they would say, oh, I didn't finish that progress note. When they complete the progress note, as soon as they complete it and refresh their screen, in our case, that just becomes a smiley face. So we're glad they completed that note. The little RN service, we've separated that out so the doctor, whether it's our psychiatrist or the medical doctor, can see when was the last time they saw one of our nurses for an RN review. And at those RN reviews, our nurses are reviewing with them their medication, how things are going with treatment, and so they can see that and look into that visit. The circle with the red X is actually a psychiatrist visit, an appointment that's scheduled, and then a medical visit would have a different symbol on it. So at a glance, and also right there, right in the middle where it says vital signs, you can see something right there. That just says that there was a vital sign taken on that day, and at least right now we've got it set. There's a little warning on it saying that it's not normal, and so the doctor can see that right at a glance in a view. And then if the doctor wants to drill down in anything that they see on this screen, then of course they can either do a flyover and see a little bit of information. And I know this may be hard to see, but in this case, there's a flyover over that vital sign, and it shows the systolic or the diastolic and possibly a BMI and what some of those were. If they want to dig a little bit deeper with one click, in this screen here, if they clicked on that vital sign, they would see all of the vital signs for that particular day. Now that one is the 423 vital sign. They could see all the details that were collected on that particular day. One of the things about the integrated record from our standpoint, we felt it was important that we have the one record. And with ECHO already having a start, since it was a certified record, it was just a matter of how could we build the medical piece into this record that for the last 10 years has been handling just behavioral health. So we had been collecting vital signs on the psychiatric side. Now we're going to be collecting vital signs on the medical side. The key here for us, though, is that the vital signs for both disciplines are entered in the very same table. And so this view here, when the medical doctor is having their visit and they pop up vital signs, they can see all the vital signs that have been taken, whether it was at a psychiatric visit, whether it was at an RN review, and all they would have to do would just be to click on that particular row, and they would be able to see the details down here, or can see what they need to see right across the screen. So the neat thing in having it in integrated record is that both disciplines very easily, with a single click, can see what the other discipline may be doing and have that history available to them very quickly. In this case, now we're looking at a behavioral health note, and I'll talk a little bit about how we work towards some of the integration using the functionality of the record. This note here for behavioral health, you can see is just a screen that has been designed, and this is actually a screen since we've been doing telemedicine for about 2 years now. This is actually the third version that we implemented last November. But the key part of this implementation and this third iteration of this note was we designed this note with the intent in mind that we were also going to be looking at providing medical care. And we didn't know when. 6 months ago we kind of had a target date of the spring, but we didn't know if it would happen. But when we designed this note, we designed it realizing that some of the information that's going to be collected is going to be shared possibly on the medical side. And so you can see something like the vital signs, that button, when they hit that button, they open up that table that I showed you previously. And when they click that, this is what they see, and they would just hit the plus sign and they would enter the vital signs for that particular visit. And then basically we gave them one-click access to other parts of the record so that they never had to leave this note to see other things that they wanted to see in order to make decisions during this visit. And so they can click on and see the client's allergies without leaving the note. They can click on and see meds that the client reported that they were taking that maybe were not prescribed by us, but that they had reported at some time taking, because we gather that in another place. They could report other problems or other visits that were, if they went to the emergency room, we wanted the doctor to be able to quickly see if they had had any emergency room visits. And so we basically gave them one-click access to that. There were many times when our doctors wanted to refer back to the comp assessment and things that might have been reported at the comp assessment. And we said, do you want to see the whole comp assessment, or do you just look at certain parts? Well, no, I only go to see just one or two things. Okay, so we gave them one-click access to those one or two things that they really wanted to see. So they can review those one or two things very quickly and be able to make decisions. But all of this was done keeping in mind that some of the things that were that they could see here and that they are going to report and collect would also be seen by a medical doctor as well as being collected by a medical doctor. And so on the previous screen, you saw a lot of drop-down boxes. On this screen, you see check boxes. As an EHR, one of the nice things about being able to design screens is you can try to design them for functionality and design them for ways to speed the visit along. I didn't mention that our telemedicine visits, and I'm still looking at the psych note. Our telemedicine visits, we schedule our doctors for 40 visits a day, and our expectation is that they'll hopefully see 32, which would be a full day. Part of being able to do that and have that kind of scheduling load on a staff person is being able to have a note that they can navigate quickly and easily, to record things, to see things, and make it as user-friendly as possible. So in most cases, if we can do a checkbox to note that they did something, or a drop-down box that gives them what the possibilities are, then we did that so that they can move through that note quickly. And in most cases, they always want to have a box where they can jot some things down. So in this case, it's just an additional information button that they can check on right here, and they get a screen where they can type in anything else that they really would like to type in. Let me go back to this one. I wanted to mention the referrals. I've got a referral button on this one as well. When we refer out to a different agency, this basically just pops up a table that gathers that information. But one of the things that we implemented 6 months ago, again, thinking along the lines of trying to get at how are we going to make an impact in our consumers dying 25 years early. The state had been talking about, of course, tobacco and smoking and wellness, and we had worked to be on board with that. We applied for a grant to get some exercise equipment with Walmart, and got a grant to be able to put basically exercise equipment in 4 of our locations and start a wellness program with that, a smoking cessation program. We've got an I Quit line here in Oklahoma. But to begin tracking all of that 6 months ago, we built into our referral file when someone is referred to our wellness program or referred to our smoking cessation program or referred to the I Quit line, we wanted to start tracking that. So again, a referral button that they could open up, they could record that information, we could then begin tracking it. It's all in one table, keeping in mind that if medical care ever came on as well, or when it came on, that we would use the same table to collect that information so that both sides could see what was going on. And so when it came time to design the physical note, now this is a completely different note, but this is a note that our medical doctor is filling out. And so when the medical doctor fills this out, they, again, get this first screen where they begin to gather their information, but you can see very quickly that vitals is one of the very first things. If they click on that vitals button, it opens up the very same table that our psychiatrist sees and that our nurse sees, and the doctor would be able to see at their last psychiatric visit what the vitals were, at their last nursing visit what they were, or at their last visit what the vitals were, so they can see them all. We had to add girth and the O2 sat in here. We wanted to start tracking some things on the medical side from the person that we had hired. She says, we've got to worry about what she called metabolic syndrome, which we had never heard of but are getting an education. And so these are some things that were needed, and we have since those weren't a part of the certified record that we've got on the echo side, we had talked with them about, hey, we really need this in the vitals, and we're told that on the next version that the vitals screen will include those things. But we wanted to start collecting them now on the medical side so we could begin to have the data. Again, the doctor can very easily see any allergies that the client may have, Wellness screen is a whole different issue, a whole different look at wellness from the medical side, so it's gathering some other information about general wellness and a full assessment. So again, gathering chief complaint, family history, getting any type of other history on the medical side. I should say that that in designing this note with our person that we hired on the medical side, it seemed like we were gathering an awful lot of information. It's like, do we really need all this information? And it was interesting, the back and forth that we had with that, because it's like, well, you don't need it every time, but we could use it and we may need it. And so it finally got to the point where I think we just came to agreement, let's get, if we could, and still hit a start date, let's get as much information in this note that we could gather, and so that we wouldn't have to maybe go back and redo it. If we're designing it this first time, we've learned a lot of things about what information needed to be gathered, so let's build it, and if we don't need it all for every client, it'll at least be there for the majority of what we're doing. And so this is a pretty comprehensive note, especially when you get to the second tab, which is a review of systems. This is a pop-up of just one of the review of systems. I believe it's the cardio system. So there's about 12 different system reviews that can be done, and all of the screens look very similar to this one that I've popped up. You can see there's a general one, there's a respiratory, a GI. This is the cardio one, and when they pop it up, they can begin to answer those questions on that particular review. One neat thing that you can do in an EHR that was very helpful, and the doctor, was very thrilled with it, was in this case, when they hit the plus sign to begin this review of systems, we default in all of the normal responses that could be there. And so they at least are able to begin with something that is useful and that they may not even have to change. And if they find something that's not normal, they can go ahead and change it. So it helps them get through the visit a little bit faster, but it also helps them with some direction on which way they're going. So it's been over the last 6 weeks as they've used this note, they've made some suggestions to us, and so we've tweaked it just a little bit. But at least right now, this is what we're working with, and they're able to have this within the same record that our psychiatrist is using, that our clinicians are using, that our front desk is using. They're accessible. And then at the end of the note, if they need to order labs, they would order the labs in this particular table, and this is the same screen again, the same concept of the psychiatrist can order labs from here. Any labs are ordered from the very same table and seen by everyone. You can see the same referrals button down at the bottom right here, the same referrals button that was on the psychiatric note. That goes to the very same table where they can put down that the doctor's referring them into the wellness program or referring them into the smoking cessation program. So that is about all that I've got here on how we tried to integrate this record. We are trying right now. We ideally would like to set up an electronic interface with the lab. We're working with the lab right now to try and do that. Right now we're just using their website where we enter the lab, and when we get the labs back we can scan them into the record. But the lab order actually starts here, and then from here it gets entered into their site. Ideally we'd like this to interface with their site and be able to get stuff back. That's what we're working on. We did just set up a portable X-ray machine at this place where we're seeing the clients, and working with a local hospital on that. So they brought in a portable X-ray machine that'll stay housed at our site. They're actually leasing space at our site for those X-rays to be done. They keep their machine there, and we just interface back with their system, and we're able to then get the any results, and the doctor's able to view them. So it's an ongoing process. I can't say that we're done. I don't know what that'll look like yet. For us, it's always been the implementation of an EHR as an ongoing process as needs change, as the climate changes, as we can find things to make even better. So,
Steve, you want me to jump in at this time, or Joe?
Yeah,
do you have any more comments?
I think that I'm done. If there's some questions,
Okay.
glad to work with Joe and try and answer some of those.
There's a good number of questions coming in. First, a couple of very straightforward questions. Crystal wanted to get the CMS link for EHR funding reposted, and I imagine she could get that if she downloaded the slides as well.
Yeah.
There was another.
I can just
Go ahead. In fact, scroll through if you wish.
There. Yeah.
The other one, while you're answering that or showing that, is from Marissa. What makes a record a certified electronic health record? That goes right back to the slide you're showing right now. Maybe you can answer that real quickly.
I'm gonna let Joe take a stab at that because I wasn't involved in it. I just took advantage of it.
Sure. This is Joe Vijay. A couple things, actually. We had, in response to the first question, Dennis, we have the CMS link up on the screen now, but as part of our preparation of creating a certified electronic health record, we gathered a lot of information because we had to become educated about it at ECHO. And so our marketing director, Paul Kirsch, had the bright idea to put that out public. We put it into basically a simple website format, and it's accessible to anyone that wants to learn more about meaningful use in certified records. So I'll give you another link. It's not in the deck, but it's an easy one to remember. It's MU, the letter M and the letter U, advisor.com. And again, that's a public website that's searchable, has all kinds of information about certification, EHR incentive programs, how to apply, eligibility, et cetera, et cetera. So please take advantage of that resource we've made public for folks. To the question about what is a certified electronic health record, essentially regulations were established through a very long process that took a variety of different shapes and ultimately became a program to certify electronic health records under a couple of different parameters. And then there were several bodies that were authorized to do evaluations of software products to become a certified product. With ECHO, we went through an evaluation with an organization called the Drummond Group last year, and our electronic health record was certified under the ambulatory regulations for a certified electronic health record.
Yeah, and certainly, Joe, on this CMS site here, if you look down the menu on the side, there is a description there that Marissa might find helpful, as well as descriptions in, if you search the website or look on behavioral.net, a description of what certified EHR technology is. And, of course, it has to be certified in order to qualify. You have to use certified technology and promise to use it in a meaningful way according to the rules so that you can qualify for the kind of incentive money that Steve LaFleur and now many other customers of ECHO and other makers of certified EHR have been able to earn through the EHR incentive program. So anything else, Joe, on that one? I'll ask another question.
Yes.
The other piece of that I can't emphasize enough is that for the first round of funding, which is the biggest bump, I think it's $21,000 something per provider. Mm-hmm. All an agency has to do is say that they are willing to adopt or implement or purchase. Correct me, Joe, if the language isn't correct, but literally they don't have to have it installed, and they have to say that they're willing to do that, and then then have the appropriate Medicaid mix, which I believe the amount is at least 30%, and then all the meaningful use criteria that you hope to meet later on for the rest of the funding, you've got to work toward in different stages. But that first round really was not that difficult.
No,
and I would challenge you to look at that, yeah.
Yeah, the word I think you're looking for, if I may jump in, was attestation. You must attest to the fact that you intend to use this technology to buy it and then implement it as directed. And on the basis of that promise, you
can get the funds and help you purchase
year.
It. Right.
Yeah.
Right.
Yeah.
Exactly.
So, that's a great question. And let me ask a couple of more questions. Why did you choose to track physical care in a behavioral health EHR, which, of course, the ecosystem was developed as a behavioral health EHR?
I think for us it was the fact, if it could be done, why not do it? The clients already live in that database. We are already serving those clients for the most part. I should say that we've begun this project with basically our consumers that we are from. This is not something that we've opened up to, the general public for people to come in and get, that we're providing, that we're a PCP for the general public. This is primarily right now for our consumers and for them to get this primary care that they may have been lacking, and we didn't want to look at another medical record. I've been going to the HIMSS conference for the last 10 years to basically see what the medical records look like, and they're a lot more robust and substantial and more expensive than a behavioral health record because there's a lot more money there. But it's always helped me to see where the behavioral health records could be and maybe should be. But the reality for us was once there was a certified record, a behavioral health certified record, it was ECHO's responsibility to build in some of those things that were primarily used more on the medical side. And so we already had the beginnings in the record. Why not take advantage of it and use our experience in the record to be able to have them within one integrated record? And our push from the top has always been, we've got this record, we've got this investment. If we can do it in one record, then let's get it done. The challenge that we're working on right now is making sure that we can get the billing out of the same record. And we're working with ECHO right now to get that done. So it'll be billed along the same 837 path that we're using right now that we have been using for years. But we'll be able to bill out our medical as well.
Okay. Just a couple points on that, if I could. Steve, just some things you've said to me over time that I think are salient and might be helpful to people are that, an integrated record is a chalkstone, a cornerstone of integrated care. That if you don't have an integrated record, to some degree, you got to question the integration of your care. And I thought that was a really interesting comment by you. And then the other piece that I think was helpful in your specific circumstance was your staffing. You had staff that were very much willing and embraced that concept. And in other projects we have in our customer base, I know not that there was opposition or resistance, it was just more culturally it was a better fit to use separate records because of the way people saw the care. Whereas in your organization, people were able to rally around that one record idea and invest in it and move forward with it. And that's always a bit of an X factor is, as an organization, what can you embrace and be successful with?
Good. Thank you for that reply. There are a couple of questions here about consumer response to integrated care and what's it like for SMI consumers receiving physical health services from you. What has been the consumer response to your care integration effort? I guess it's slanted. Maybe you see what you want to see, but I was at the office on a Wednesday 2 weeks ago,
and saw the clients coming in, and the things that I observed that would lead me to believe that things were going well. When that consumer walked in the office, they saw support staff that they already knew. They saw a building that they were familiar with. They went into an exam room that was much different than our group rooms or anything else that they had seen in that building. But I think that the comfort level was instantly there. We had already transitioned. Our telemedicine is actually taking place in the very same hallway as the medical care. So the clients that have been seeing the psychiatrist were coming into the same waiting room to see the physician assistant for medical care. So instantly there's a comfort level that medical care can be provided in. So that was just a big plus. So I think from that standpoint, from the consumer standpoint, I mean, we've not done surveys or anything like that yet, but I just saw the comfort level of those consumers being called by name, and those consumers, coming back into a building that they were familiar with. So, there's where I see my psychiatrist. Yeah, we're just going to be right down here, and you're going to meet with our physician assistant. So,
okay. There's a lot of questions, and of course, if we don't get to all the questions in the course of our discussion today, we will keep those questions offline, right, and get back to the individuals who sent them with a response, correct? So I just want to keep that in mind. Bonnie, or for Brenda rather, asked, do you have any detail on the behavioral health treatment plan within this, Steve, that you could show, or does your demo not include that particular plan?
I don't have anything on the slide deck to show what our behavioral health treatment plan looks like.
Okay.
Our treatment plan, we designed that. The neat thing about this record is we've been, you can design the screen, so we've been able to design our treatment plan to fit our processes and what we need. So, but the neat thing is with the EHR, they can pretty much see the status of that. They can see the status of that treatment plan. As soon as they pop onto a client, that green bar says that this is an active treatment plan. It started on this date, and there's some ending date out here in the future on 12. I can't really read that right now on the screen, but this date right over here actually shows the ending of that date. But a green one means it's active.
Okay. A couple of other questions about primary care support. First of all, did you have to get anybody in to help you develop the support for primary care? Then how the doctors supported it, and thirdly, what kind of care coordinator? Is it a medical person or a behavioral health person who's doing the care coordination part? So maybe you can address all those questions.
The help that we got in was this person that I had suggested. We titled it an integrated care coordinator. And she was from the medical side. She actually came from an FQHC and had been in that world most of her career. And from the state that we visited, was very familiar with the move toward integration, and was excited about the possibility of what that would mean in a behavioral health center, having kind of a FQHC service that was there. And initially, this person was involved with the grant to try and get an FQHC, and then when that didn't work out, of course, that didn't work out for her. But then we were able to offer her a position and say, hey, what about providing this very same service in this building that you were looking at anyway, and working with us on that? So when she came on board, that was the biggest assistance that we could get. As far as the actual medical staff person, the PA that we're using actually has behavioral health background with her physician assistant. It was actually someone that that we had known about previously, and we were able to get her back and say, would you be willing to do this? So she was the biggest assistance, her and this integrated care person, in designing that medical progress note to be able to gather what we needed, and then what information do we need to gather to begin to get good to begin to measure and be able to see that we're getting good outcomes. So that's why there's so many pieces on that
Okay.
record.
Now, are the doctors or PAs directly using the system, and if so, how are they entering the data, and are they doing it at the time of the examination or the assessment or the visit that they're having?
Yeah. On the medical side, they're entering it. They're entering all that information while the client's there. There's the nurse that's gathering some of that information when they first see the client. They may fill out some parts of that note. When the physician finally sees them, then they're filling in their portions on that review of systems. So they're responding pretty much either with that, while that client's there. They've either got a nurse assisting them with that, but pretty much by the end of that visit, the only thing that's left to be done is for the doctor to determine what the diagnosis is and what kind of treatment's going to be made. But they can do the prescription right from that note. They can jump right to our e-prescribing piece of the software and get that taken care of. So it's done pretty much concurrently. Our medical, on the psychiatric side with the telemedicine, it's filled out the combination of the nurse and the doctor while the client's in there.
Okay, so it's all done concurrently.
Yes. That's the intent.
Okay. With that, I'm afraid we're about out of time for questions. One interesting suggestion from Jesse, will there be a webinar on the integration of teams and mental health and medical staff working together, and how that teamwork and process development translates into an EHR? Interesting question for the future. That's a great suggestion, Jesse. And with that, I do need to thank everyone. We'll have to conclude the questions right now. Let me just wrap up on a couple of things. For information about upcoming behavioral health care webinars, be sure to visit us at behavioral.net and click the webinars link. I believe that's in our resource tab. Also, feel free to join our online communities, Facebook, LinkedIn, Twitter, and participate in the discussion with all of us. Thanks, of course, to our speakers, Steve and Joe, today. Outstanding presentation. I know you've been working on this for a long, long time, and it's great. I know it's got to be great to see it all come together and be working very well. For those of you who viewed presentation today and need CE credit, if you're an individual, stay online and logged in. A link will appear on your screen in a couple of moments that allow you to generate your CE certificate. Again, if you're viewing as a group and want to obtain your CE credit and you're registered for the event, be sure to record a little number from the box that appears on the screen and then fill it in the follow-up email so that you can get your CE credit. Also, this program will be archived for a year for your convenience and for sharing with colleagues. And within the next few days, you'll receive an email with a link that will allow you to download the presentation slides and also a recording of today's event. So let's see. Thanks again to everyone, Steve LaFleur, Joe Viget, and all the folks in the background who help us put on this webinar. And we hope you join us in the future for another behavioral health care webinar. We will save the questions we didn't get to and get back to you on them. And with that, I'm Dennis Grantham. That concludes today's presentation. Thanks to you all.